I think I might get started. It's just about 12:30 by my watch anyway. So it's nice to see you all. I'm one half of this duo. I'm Michelle Leach, Assistant Professor in the discipline of Radiation Therapy in the School of Medicine. So in this talk today, sorry, I have to stand here because this is being recorded seemingly, so I can't move over there. What I'm going to do today is tell you a little bit about the profession of radiation therapy, what the job entails upon graduation, and then a little bit about our course. Maybe some of you have already visited our stand in Luce Hall, and if not, we have some flyers over there that might be useful for you. And at the end then, I'm happy to take whatever questions you might have. So I suppose one of the main questions that we often get asked is what's the difference between a diagnostic radiography and radiation therapy? And I suppose that comes from historically, say when I would have taken this as a primary degree a number of years ago now, the degree would have been in therapeutic radiography, so therefore you were called a therapeutic radiographer. So the title has changed to reflect practice across Europe. So now the term that is used for us as health professionals now is radiation therapist. And that's recognised by our European professional body. So similarly then, our degree has changed in title from a BSc in therapeutic radiography to a BSc in radiation therapy. So what's the relationship to diagnostic radiography? Come on in. There's loads of seats down here in the front. So, sorry, I also forgot to say, when this talk is over, please exit through this door here where the clock is. So it's just so there's not a backlog outside. So the main, I suppose, relationship that we have with diagnostic radiography is that we're part of the same professional body. And what a professional body means is that every health profession, if you like, has a professional body or society that basically looks after things like your professional competence. Are you keeping up to date with new practices? So obviously, you know, in health sciences, you don't just take a degree and learn something once and that's the end of it. Things are always constantly evolving, so you always have to keep up to date with your practice. So that's kind of what the scope of the professional body is. So we're part of a professional body called the Irish Institute of Radiography and Radiation Therapy. Nice long title. And that represents both diagnostic radiographers and radiation therapists. And we have a website that might be useful for some of you to have a look at. It goes through a little bit more about both professions. So it's just iirrt.ie. So the main differences, I guess, between diagnostic radiography and radiation therapy is, I suppose, first of all, the patient population or the different patients that we see, and also our relationship with the patients. So in diagnostic radiography, you would really only see a patient while you're conducting a certain examination on them. So an ultrasound or a CT, MRI or a plain X-ray. So obviously you're with the patient for that length of time. And you see a range of different, if you like, types of patients. So from those who are, you know, in maybe road traffic accidents to being diagnosed for cancer, or you know, if you're an ultrasound, maybe pregnant women, you know, so on and so forth. So it's quite a varied patient population, whereas our patient population is practically 99% cancer patients. Okay, so as well as that, we are in a position, I suppose, to have quite a unique relationship with a patient in that we see the patient every day for over a course of treatment. So a course of treatment, say for a typical cancer like prostate cancer, could be in the region of maybe about 7.5 weeks. So you would see the patient every day, 5 days a week for that length of time. So obviously you get to form quite a good bond with the patient over that length of time. So that's, I suppose, quite a main difference between the two professions as well. From a more technical perspective, the type and quantity of radiation between the two is very different. So for diagnostic purposes, we tend to use low energy X-rays, and they're in the range of what we call kilovolts. Okay? So you make them like 1,000 volts, kilovolts. Whereas in radiotherapy, we use much higher energy X-rays, and they're in the range of about 1,000 times kilovolt, and they're called megavolts, so MV. So the type and quantity of radiation is very different between the two. So then, I suppose if you wanted to define what radiation therapy actually is, it's a specialised branch of medicine that is concerned with the treatment of malignant disease. So malignant disease meaning cancer. So as I said before, we use very high energy, and I suppose it's important to point out potentially lethal doses of radiation to destroy malignant tumours. So I guess why we say potentially lethal doses is to get across the point at a very early stage in your education that you are, I suppose you're dealing with quite a serious intervention like radiation. So therefore you have to be extremely careful when you're using it. Because you don't want to overdose patients, you don't want to underdose your tumours. So you have to be quite accurate and quite precise in your work. It's not just solely a technical job, because obviously, you know, tumours they're on their own, they're actually inside a patient or inside a person. And sometimes people can overlook that and get very focused on the technology, especially as the technology develops more and more, and actually forget that you're also you're talking about a patient. So it's our role and our responsibility to treat the patient as a whole. So we have a holistic view of therapy. We don't work on our own. We're very much part of a multidisciplinary team, and that's a standard of care in cancer treatment. So we're a very important part of a team, which would include, say, oncologists, and of course there's different types of oncologists. So there's surgical oncologists, so say surgeons who perform, they're specialised in surgery for a particular, maybe breast cancer. Then you have medical oncologists, which are the doctors involved in chemotherapy. And then I suppose the oncologists we work most closely with are our colleagues in radiation oncology or radiation oncologists. Similarly, physicists are a very important part of our team as well. So we deliver x-rays using very specialised equipment. So it would be, say, the physicist's role to make sure that the equipment is operating correctly and that the dose that you, as a radiation therapist, anticipate that it's actually delivering to the patient is the dose it's actually delivering. So that would be very, very important. So obviously as well, there's other disciplines that we work with, say our colleagues in physiotherapy, in occupational therapy, clinical psychology, speech and language therapy. So we human nutrition and dietetics. So we work across a wide range. But I guess from our perspective, even though we work in these teams, once the patient begins radiotherapy treatment, we are really the people that the patient sees every day, regardless, because they come for treatment every day. So they might see the radiation oncologist maybe once a week or once a fortnight, but they see you every day, which means then you have quite a substantial responsibility in their care. So just to go through a couple of things and show you the different aspects of work that we work in. So obviously before you can begin a course of radiotherapy, there's an awful lot of very precise pre-treatment considerations. So first of all, if you're obviously delivering a high dose through a beam of radiation to a patient, you want to ensure that the patient is in the correct position for that treatment and that they're not moving. Okay? So this is just a case of preparing what we would call an immobilization device for a patient. So this particular one is obviously where you see it's being made. It's for a patient with a tumour in the head and neck region. And this type of mask is called a thermoplastic mask. And it's so called because that sheet of plastic is a thermoplastic that becomes malleable when it's heated in a water bath. Okay? So it comes in a flat sheet, it's heated, it becomes soft or malleable, and then 3 radiation therapists basically what we call mould, or if you like, lightly kind of touch the patient's face with this material and take an impression or shape of the patient's face. So that's one type of immobilization device in the head and neck region. This one looks a little bit scarier. This is a different type that eventually ends up in a perspex type mask. And in this case, we would take an impression of the patient's face using their plaster of Paris bandages. You know, the same as if, say, you broke your wrist and you have it set in plaster, the same type. So they're left on the patient's face for about 5 minutes, making sure, of course, that their airway is maintained, so you don't cover the nostrils or the mouth. And what happens when that is finished is that you are left with this kind of cast of the patient's face. And then this cast is brought to a workshop where it's filled with liquid plaster, allowed to set. Quite a number of other things have to happen to it, but eventually it ends up in this kind of perspex mask here. So either of those are suitable for immobilizing a patient's head and neck area. Okay, there's really no difference between the immobilization offered by one over another, really, in reality. This one, you can imagine, is probably a little bit more difficult for the patient. It also requires 2 visits to the department, whereas the previous one can be made in 1 sitting. And also, it's a lot more work for the team involved. So really, depending on the department you're working in, people usually go for one over the other. Another purpose of these types of immobilization devices is to apply marks so that we as radiation therapists on the treatment units then know where to direct the beam. Okay? So for example, obviously if we were treating someone, say, with prostate cancer, we can give them very, very small tattoos that are literally like a pinprick. They're really, really tiny. But obviously it's not acceptable to do that to someone in the head and neck region. So another purpose of these types of masks is to actually allow you to apply marks onto the mask so that the patient is not tattooed in the head and neck region or somewhere visible. So that's one, I suppose, the initial aspect of pre-treatment care is making masks or immobilizing the patient. And similarly, they're just immobilization devices for the head and neck region, but there are immobilization devices, say, for the pelvic region, obviously for patients being treated with breast cancer, for lung cancer, and so on and so forth. The next stage, really, before a patient would attend for or commence their treatment is the treatment planning stage. And treatment planning in radiotherapy means something very specific. It basically means calculating the doses to the tumour and to normal tissue. Okay, so this is just an example of that. It's quite a physics-based role. Okay, so I guess it suits some radiation therapists more than others. But for example, here's just an axial CT slice through a pelvis. This is a prostate patient, and this kind of circular, if you like, or elliptical structure here is the prostate and seminal vesicles, which is the area that is to be treated. And so areas that you're trying to minimize dose to are the rectum here in the patient, the bladder in the patient, and the heads, like the hip bones or femoral heads. So what you're basically trying to do in the treatment plan is decide where your beams, and these yellow lines coming in are showing where the beams are coming in. So where should they converge to give you the best dose or the highest dose to the tumour and lesser dose to the organs at risk. So that's called treatment planning. Okay, that's a really important step in the procedure because, for example, how good your treatment plan is and how well it's executed really is going to influence, say, the probability of controlling the tumour or curing the patient. So it's a very, very responsible job in treatment planning. So this is a linear accelerator. Some of you may have been in a radiotherapy department before, were you? Show of hands, anyone? Couple. So those who have seen it know these are, I suppose, from the patient's perspective, they're quite intimidating pieces of equipment when you see them for the first time, and they're quite noisy as well. So it's important to remember that. I suppose as years go by as a student and as a qualified member of staff, you get so used to it that after a while you don't even hear them. But it's really important that you always take the patient's perspective. So coming into a room like this for the first time, and of course the patient has to be in some kind of state of undress depending on what area you're treating, it's extremely intimidating for a patient. But the linear accelerator is composed of various parts. This here is the treatment couch. It's quite narrow, and it has to be narrow so that this part of the machine, which is called the gantry, can rotate around the patient 360 degrees. So basically, you can treat the patient from any angle that is appropriate for that given area. Okay, so that's basically what the linear accelerator looks like. They're housed in quite large rooms that have obviously extensive shielding in all directions, so in the ceiling, in the floor, and in all the walls. And also you might notice, if you do visit a radiotherapy department, that there's quite a long, if you like, tunnel from the treatment room out to the control area. And that's to minimise basically because X-rays travel in straight lines, is basically to minimise the amount of radiation that actually comes out the door. So you don't have to worry about in this job. Sometimes people ask, or patients will ask you, am I radioactive after treatment? Particularly maybe some older patients with grandchildren or children or daughters who are pregnant, they're always afraid of, oh, you know, can I see my daughter or can I see my grandchildren? And of course, no one is radioactive after radiotherapy, because these X-rays are high energy photons are produced by electricity. So the minute the machine or the treatment unit is switched off, the radiation is gone. Okay. So as a radiation therapy professional, we do wear dosimeters, which are little monitors, if you like, that measure dose that we receive. But actually, in radiation therapy, I think it's been proven, if you were a flight attendant, because you're so high up, you actually receive more radiation than you would working in this field. So that's not an issue. Again, just showing you, here's a radiation therapist using, we've handsets for obviously controlling the motion of the unit in various directions. So I suppose, what kind of skills do you require? This is an area that you're considering for your profession. You really have to be, I suppose, a bit of a multitasker, and also what we'd like to call a bit of a perfectionist, which sounds, I suppose, a little bit narcissistic, but a very high degree of technical knowledge and accuracy is required for this job. Okay, so if you think you have responsibility, if you're kind of technically inferior, then you could impact on that patient's likelihood of cure, and that's a very serious responsibility to have. Similarly, I suppose why you need to be a kind of a multitasker is you need to be like that, as in very technically minded, but also you need to have really good people skills as well. Okay, because you can imagine, and I'm sure some of you in the audience may have had some family members or friends who have had cancer, and you realise that this is an extremely difficult time in any patient's life and in their family and in their friends' lives. So you really have to be someone who can assist the patient throughout that difficult time, as well as giving them technically excellent treatment. Okay, so that's a little bit about the profession and the job. Okay, so now getting back to our course. Excuse me. So we offer a BSc in radiation therapy. It's an honours degree course. It is a 4-year course, and I guess for kind of ease of talking about it, we divide it kind of into the first 2 years, or the freshman years, as we call them in Trinity, and the latter 2 years are the sophomore years, as we call them here. So the first 2 years really, I suppose, focus on the basic sciences. Okay, so in first year you'll cover general physics, chemistry, biology, anatomy of the thorax and pelvis, and then there's this module that we have throughout all 4 years of the course called Principles and Practice of Cancer Care, or we call it PPCC for short. And in first year that deals with things like integrating you into a hospital environment, because I'm sure the majority of you would be coming from school, and it's very difficult when you're coming from school to then get used to, say, being on clinical practice placement in a hospital environment, which is completely different from a school environment. And also we have modules in psychology and communication, because again, it's very difficult to expect someone who's 18, 19, 20 to be able to go into a hospital environment where people have cancer and to be able to cope with that on their own. Okay, and know what to say to people and how to address their needs. In second year then, we have anatomy again. Anatomy in second year, I suppose, is in 2 parts. There's what we call cadaver anatomy of the head and neck, and neuroanatomy, so say the brain and the spinal cord. And we also have a module in radiographic anatomy, because it will be very important that you can apply your cadaver anatomies to radiographic images, okay, because that's what you'll be working with. We also have physiology, biochemistry, so physiology leading on from biology, biochemistry leading on from chemistry. Again, psychology and communication, And then from second year, the physics gets very specialised to radiation physics only. Okay, so for example, radiation physics, for any of you who are doing physics at the moment probably know, but it would deal with, say, those pieces of equipment we were looking at, basically how they produce radiation, the interactions of that type of radiation with the patient tissues, those kind of things. Again, the PPCC continues in second year, and then we also start to introduce research methodology and statistics. And research is a really important part of your role in any healthcare profession. Okay, so we're always constantly researching and trying to find better ways of doing things for our patients. So by starting, I suppose, a process of how you will conduct research in second year, that helps you become quite an adept researcher by the time you have qualified. So the latter 2 years, or the sophister years, then consist of quite an in-depth study of, say, cancer and its overall management. So therefore you would start looking at very specific cancer sites. So you'd learn all about breast cancer, head and neck cancers, brain tumours, so on and so forth, every area. And also the professional skills of radiotherapy. So for example, how do you know what is the best, say, beam arrangement for treating someone with a particular stage breast cancer? Okay, so you get very specific at this stage. Self-development is also really important because I suppose as you're coming towards graduation, it's important that you realise that you can't be a very adept health professional unless you're kind of looking after your own health and, say, how you deal with maybe treating children or adolescents with cancer and things like that. So we look after those things as well. And then healthcare management is only in fourth year, and that's really, I suppose, getting you to see the whole picture of how you would manage a treatment unit, how the radiotherapy department fits within the structure of the hospital. So it's quite specific for those who are about to qualify. And of course, at this stage then, you do have to complete quite a substantial research project in an area pertaining to radiotherapy. Clinical placement obviously is going to be an integral part of this course, because you have to, the actual skills of getting patients into the correct position and things like that, they're learned in the clinical setting. Okay, they can't be learned in a university. Okay, so there's about 40 weeks clinical placement in total over 4 years, but they're very much, I suppose, weighted towards the latter 2 years, third and fourth year. It's important to tell you at the outset that a lot of placement can take place in holiday time. Okay, so we generally try to not have placement in holiday time in second year, because that's usually the year that a lot of students like to go off to America or whatever on J1s at that stage. But certainly in the year between third and fourth year, there would be a substantial amount of placement in that period. The placements vary because really in the first 2 years, you're kind of orientating yourself about in the hospital environment. So they're kind of short introductory placements. And then they're very specific and of much longer duration in the latter 2 years. It's important to note that we have radiotherapy departments throughout the country, okay, both public and private, and students are placed in all of those. Okay, so you basically, as a student, you don't get to say, oh, I just want to go on placement in whatever St. James's in Dublin. You don't get to do that. You have to have, I suppose, a wide variety of experience, so therefore you're placed throughout the country. So for example, there's public departments in Dublin, Cork, Galway. There are private departments in Galway, in Dublin. There's one in Limerick that's associated with the Mater Private. So you're placed, over the 4 years, everyone is placed in all of those. Okay? And that's to ensure that you have kind of equitable experience. The assessment then is a mixture of continuous assessment, project work, and practical assessments, and also just straightforward exams. Okay? Continuous assessment can be difficult if you come straight from your leaving cert, although I think they are trying to address that now, aren't they, at second level, because people are very obviously points focused and trying to get their points, and they're learning everything off by heart, whereas obviously when you come to university, your learning is completely different. You take responsibility for your own learning, and the lecturer doesn't, it's basically an adult-based approach. So that can be a little difficult in the beginning for students to get used to. In the final year, the clinical portfolio and your thesis really make up the majority of your grade in the final year. So then people always ask us, well, what's the likelihood, especially I suppose in the current climate, of getting a job in this career? So at the moment, radiation therapy under the National Cancer Control Programme is totally expanding in Ireland. So we have new centres that have opened in Beaumont and James's as part of the St. Luke's Radiation Oncology Network, and they're going to almost treble in size over the next 5 years. So therefore, if you're a graduate and you want to stay working in Ireland, we definitely anticipate there's going to be a lot of opportunities for you. And if you're someone who, and a lot of students do like to travel obviously, if you're someone who wants to travel, the qualification is recognised worldwide. The only thing is upon graduation, I think it is in Australia that you need to have a year's experience before you can work in Australia.